Good morning. I have to admit I'm a bit surprised to see as many of you here today as I was at the party last night. And one of the reasons I became a psychiatrist is because I love psychiatrists. I think they're particularly interesting people who choose this specialization. This is in the Swedish context. I chose psychiatry, but I think you guys are actually more fun. All right, so we're going to talk about autoimmune disorders in the context of psychiatric disease. And these are my disclosures. Okay, so I think to understand where I'm coming from, or like where anyone's coming from, you have to know what they have for a background. And the way I'm approaching psychiatry, I think, is shaped by what I learned first. I was a pre-clinician first. I did an undergrad at McGill University. I'm Canadian. I grew up in the south of Quebec, and my focus was immunology and microbiology. And I came to Sweden as a preclinical researcher in endocrine oncology. So these are rare endocrine tumors in the gut and in the other endocrine organs. And most of them have presented to psychiatry before their diagnosis was made. And the diagnostic delay is 15, 20 years in some cases. So I guess I was primed to be looking for unusual things that show up in the system at the wrong place. And I've worked, you'd think that the gut, this is so different from psychiatry, but I can tell you it's exact same signaling systems. The gut and the brain, there's not a lot of difference. And I've worked on some genetic studies and some familiar studies there. And so I shift to psychiatry, and a lot of my colleagues sort of raised an eyebrow. Really? Why, Janet, would you choose that change? And beyond the fact that I love the psychiatrists, I love the psychiatric patients. I think the work we do is so challenging. I get to use my entire background and my entire self in trying to figure out what does this patient need from me right now. And I think that is really challenging and stimulating, and I can see that I can make a difference with the background I have, and I love that. And then the timing was also very important. The NMDA receptor story came out just about the time I was making my decision on specialization, and that and a couple patient meetings I had really shifted my view on what psychiatric disease could be. But I came from oncology, and they had built a biobank like 50 years, and so any question you had, you just went to the freezer and you could answer it, right? And I said, okay, where's your biobank? And the psychiatrist looked at me and said, we don't have one. So I was given an opportunity to, with a combined research clinical internship, to start building. So we built a biobank over many years, and we've hooked it into different projects, and so now we're exceeding 12,000 samples and over 2,000 patients, and now it starts to get interesting. Now I can start to do the work I wanted to do 10 years ago. So the biobank and the projects we've built up, I've been backing away from the DSM system, and that's raised a lot of eyebrows in my colleagues as well. You need to focus on one diagnosis, Janet. Nobody knows what you're doing. And I really want to challenge that, because I think that's the wrong approach. But frustrated with the way the world looks, and sometimes you have to accept it, and so I said, okay, fine, I'll show you. And so I took all my samples from OCD patients, and we did a multiplex study. And so I time-separated 2 separate cohorts, and we did mesoscale analysis, and we did O-link analysis, so 2 different platforms. And here are the results. So here you can see the first cohort and the second cohort. And these are known markers, IL-6, IL-8, IL-12. And in cohort 1 and 2, IL-8 shows up, and in cohort 1 and 2, IL-12 shows up. So, replication study, by the book. My PhD student was so excited. We're going to publish this, it's going to be replicated, valuable data, and I was like, no, we can't. And they were really annoyed with me. And I said, no, this is only group differences. This is not what's interesting. And I plotted it out and showed her. This is what it looks like. So the markers don't overlap. The high IL-12 cases and the high IL-8 cases, they're not the same patients. All right? And this is really important. They're not the same patients. And these are like, got away on me. So these are like normalized, so this is like an exponential scale here. We've got some outliers here, and they're not the same patients. And the only thing, and sometimes I meet colleagues that have been in the business a long time, and they say, oh, it's only outliers. And when you're in the clinic and trying to target biological processes, the outliers are the only ones that count, the only ones. Our focus has to be on the outliers, because that's the only one that's relevant for targeting that system. So the thinking in psychiatry is backwards. I know I'm swearing in church, but I really, really believe this, so you're going to have to attack me at the Meet the Expert session later. So if you look at the controls, we only have a small cluster, and I think those are the ones we really should be looking more closely at. The other thing we did is, now we're following these patients we're collecting in the register, so we're able to see the diagnoses they're accumulating over time. And in the OCD group, there's a lot of immunology in the comorbidities. Severe allergies like angioedema was actually really common in this cohort. Other asthma and allergy diseases, autoimmune diseases, metabolic syndrome, chronic infections. This group has a lot of immunological problems. Again, these disorders aren't really overlapping with each other. They're separate groups. The word inflammation gets thrown out as like a one-size-fits-all. But I want the question to be from now on, which type of inflammation are you talking about? The immune system is very complex. And to be working properly, it has to react at the right time, in the right way, in the right place. And it has to be able to turn itself off and clean up the mess when it's done. And I think our patients can have problems at any point in this procedure. And they can react too much or too little at any one of these points. And the different patients will be having problems at different points, and we have to treat those conditions differently. We can't have a one-size-fits-all immunological treatment for all of psychiatry. It's never going to work. So that's my caveat. We're also looking into some rare mutations with functional impact, and this is in the PANS group, and we're finding actually a lot of really interesting things in DNA repair and ubiquination. A lot of it is the mess cleanup. And I think that's going to be an interesting story that you can watch evolve. All right, so this would be like a typical patient for me in our multidisciplinary clinic. This is a woman in the late 40s, and she's a well-educated professional. She has a very high-level job and previously full-time employment. She's now working 40%. And the past year, she's been convinced that she's infested with some type of bug, and she thinks about this all the time, and she shows me on her camera videos, like thousands of them, where she's trying to capture this insect that has infested her. Tried every cure she can find on the internet. And she's been diagnosed with, some type of psychotic disorder, delusional disorder, OCD she's gotten as a suggested diagnosis. They've started to talk about personality disorder, although she's had a high function before. And she's not responding to the antipsychotic treatment. She's not responding to antidepressants. And so she got sent to me. And the reason she got sent to me was because she had an ulcerative colitis diagnosis. And the question was, well, Janet, this wouldn't have anything to do with the ulcerative colitis, would it? Because they're getting better at this. And the interesting thing is that her ulcerative colitis was, according to the gastroenterologist, under excellent control. And she didn't have a lot of gastrointestinal symptoms now. She had, 3-4 diarrheas a day, but compared to what she had at the start was nothing. But her calprotectin was slightly elevated. The gastroenterologist sort of yawned. He's like, it's barely over reference. And she had been treated with TNF-alpha inhibitors, but they had discontinued them 3 years ago. We did a CSF sampling on her, and everything was normal except her GFAP levels. And GFAP is, at the levels we're measuring it, is a marker for glial cell activation, so astrocyte cell activation. And I don't know, but I've recently understood what the astrocytes really are doing as part of their functions. One of the things they do is they act like a sponge for glutamate. So when you get a lot of glutamate signaling, the astrocytes are there and absorbing the extra glutamate in the surrounding area. And it's tickling to sort of hypothesize that maybe this elevated GFAP is reflecting a reduced function in the astrocytes and their ability to absorb the glutamate, and that might be linked to her extrasensory hypervigilance for symptoms, right? And overinterpretation of what she's experiencing. So my job in this was to do the workup, do a timeline, and then talk to the gastroenterologist and say, hey guys, can you put the TNF-alpha inhibitor treatment back in? Really? Yeah, just trust me. Yeah, but it's a psychiatric symptom you're trying to treat. Shouldn't you guys do it? And I think in the long run, I think we should, or at least be part of a team that is making these decisions together. I got them to put the TNF-alpha inhibitor treatment, and she disappeared as a patient in us. And she'd actually been very medial, and she actually wrote a little notice in the paper that her bugs had now been resolved, and she didn't need to worry about this anymore, realizing, backwards how much of a problem she had made. So these are my my clues here. The regular treatment was minimal efficacy in the regular treatment. She has an autoimmune disorder. She has slightly elevated markers for the disorder, and she had a CSF sample abnormality. And then she resolved. And there's a lot of different reasons for why we're seeing the psychiatric activity in patients with autoimmune disorders of the gut. Beyond the fact that the treatment and the disorder is quite there's a lot of stigma involved in having gastrointestinal symptoms. And there's pain, there's malabsorption, so maybe there's deficiencies. White matter changes are well described, and atrophy are well described in this patient group over time. And there probably are genetic vulnerabilities. This is one of the gene categories we're seeing showing up in, for example, the pediatric autoimmune encephalitis group, is related to gut function and gut barrier function. And the chronic inflammation in itself, there's a secondary effect on how the brain works. All right, so my focus today is on severe psychiatric disorders. So this is a different story from the low-grade inflammation and depression and the metabolic depression story. Very different story. I want to make that very clear. We're focusing on severe disorders and specialist psychiatry, inpatient and intense outpatient care. So an autoimmune disease is when the body's own immune system has harmful effects on the body's tissue. And we see that there's there's an inheritability to autoimmune disorders that is following mental disorders. So if you have a parent with an autoimmune disorder, the risk is higher for the child to have a psychiatric disease, and the opposite direction works too. And external factors are interacting with this. So the more infections you have, the higher your risk is for example, psychosis. But if you have an autoimmune disorder and many infections, that risk is potentiated. So it's not 1 + 1, it's 1 + 1 is 3. And in Uppsala, if you look at the registry, all of the patients within specialist psychiatry, they have about 50% higher chance of having an autoimmune disorder, comorbid, compared to the background population. So, we've got a lot of autoimmune disorders in our cohorts, about 1 in 10. But if you look at the patients in cohesive care and requiring the most care, it's actually quite a bit higher. It's about 20% in that group. So we've been following some cohorts over time here, and the two biggest parts of our sampling is from the young adults clinic. So these are general psychiatric disorders, mostly affective disorders, 18 to 25-year-olds, and we're at about 1,200 patients now. And the immunopsychiatry clinic, that's a multidisciplinary clinic. It's a very selected group that are referred to me because they think there might be an immunological association to the disease process. So in my young adults clinic, when they came to us at baseline, 6% had an autoimmune disorder, and this is, they're 18. So it's a pretty high number at that age. But after our follow-up period, and it's a median of 5 years, we're at 9% now, and that number is still growing. Autoimmune disease in our selected cohort, that's 25% had it at baseline. But after the workup and the follow-up, we're now at 34% of those patients have a known comorbid autoimmune disease. And I think this is kind of interesting. 13% about in these cohorts combined have several autoimmune disorders. And actually, that's one of the biggest risk factors for an autoimmune disorder is you have another one. And there's some clusters, right? So thyroiditis and celiac disease go together, and psoriatic arthritis and ulcerative colitis go together. So there's some clusters of diseases that go together. So one of the first questions I asked was, so what? Does the autoimmune disease in the psychiatric patient influence the psychiatric progression and what we're doing in psychiatry? And I often get asked too, what patient group are you interested in? What diagnosis are you interested in? And I've got my answer confirmed in the data. The patients with autoimmune disorders, it's not a one ICD code. It's the ones that are getting a lot of them. And that's what happens to a patient when it's a bit weird, right? That starts out with, it's just an anxiety disorder. No, this is a little weird. I think it's an OCD. Maybe it's a trauma. Maybe it's a personality disorder. No, this is psychosis. No, that's not psychosis. This is autism. I have patients that literally have every single category you can get in the DSM. Because they're being bounced around, right? Everyone sort of feels they don't quite fit. And they're not responding to retreatments as you expect, and they're the misfits in our system. They're also getting more drugs over time, so there's more drug trials. And they're showing up at the emergency room more often. They're subject to LPT or to the cohesive care more often, and they're coding more often for suicide and self-harm codes. So it's a group we're struggling with. This is data that's come out pretty recently now on MS, and I think this is just so fascinating. This is looking at multiple sclerosis patients the 15 years before the MS diagnosis is made. Okay? So here's the MS diagnosis made, but what happened in the 15 years? Take that in. That's a long time. What kind of healthcare usage do they have? And so here's neurology, and so one is that, no difference. Ophthalmology, general practice, so not seeing much of them there. Emergency medicine, a little bit. Radiology, yes. Look at that. Psychiatry. That's 11 years before the MS diagnosis is made. I want you to take that in. This is not just MS. This is the way it is for SLE. It's the way it is for rheumatoid arthritis. This is the way it is for most of the other autoimmune disorders. They show up at our doorstep first. And one of our studies, we got a marker for SLE that showed up, and I went back to the clinical journals to look at, did they have a lot of symptoms? In 60% of the patients, the somatic symptoms were not described at all. Not negated, not described, nothing. I think we contribute to the diagnostic delay. And that's, if you take anything home, I really want you to remember that we're doctors first, and that our major job is to make sure that there's not other medical disorders, and that we're not missing them. And with all this AI coming in that are going to be looking through our journals and trying to cluster things, if we haven't described the bodily symptoms, we're contributing to the bias this technique is going to make. So start asking your patients how they're doing with their body symptoms, please. Ask them about morning stiffness and joint pain and eyesight problems and any problems with their, their mouth or their nose and their genitals. My SLE patients, like several of them have had ulcers in their vaginal areas. As a psychiatrist, I don't ask that question. Now I do, because that can make the difference between an early and a late diagnosis. All right, so in Germany and Hanover, they started doing CSF, lumbar punctions, on their severe cases as a routine. So it was optional, the patients could opt out, but when they started doing it, and they've just published this data a year ago, and I think it's kind of interesting data because 8%, a little over 8% of their patients received actually a new diagnosis. In 3% of cases, it was an infection, but in 5.3 cases, it was some type of autoimmune-mediated inflammatory CNS disease, of which the majority were MS. And NMDR receptor encephalitis, it was the other big number. And they didn't look at the other systemic autoimmune disorders, the peripheral disorders. So I think there's probably more to find here. And they do have a fairly big group that have markers, but they don't know what the diagnosis is. And I just want to make sure you are aware of the fact that the McDonald criteria for MS has been updated. So you can have psychiatric symptoms alone if you have the other markers. That was something that drove me bananas a couple of years ago. I had radiological MS in a patient with really weird psychiatric presentation, and the neurologist was like, oh, but there's no neurological symptoms here. And they were not offered treatment. Drove me bananas. So this has been updated, and this is something you can use in your argumentation. All right. So the NMDA receptor encephalitis story is a start of a journey that we've just entered. And neurology, these used to be really rare cases, but now I think about half of the referrals that are coming into neurology now, at least in Uppsala, have to do with some type of autoimmunity in the nerve system. So the neurologists are doing their homework, right? And there's a whole bunch of new antibodies linked to neurological conditions. The psychiatrists are not on the train yet. We are not describing yet the antibodies that are related to things that show up in our doorstep. So I think we have that work to do. And just a reminder, there's, it's not all autoimmunity. There's a lot of differentials. When you evaluate a patient, you always have to be starting with, a very broad mind and make sure you're not missing completely other things. All right, so this is the epidemiology data from Canada showing that and this is rheumatoid arthritis and ulcerative colitis and MS in this data set. And you can see that they're showing up as anxiety disorders and depression and bipolar disorder and psychosis. This is the year of the diagnosis. This is 5 years before. So they're showing up at our doorstep over 5 years before the primary or the autoimmune disorder is diagnosed. So can we find these cases? We know the known autoimmune diseases, that's the low-hanging fruit. If you've got a patient with a known systemic autoimmune disorder, work with the other specializations around the patient to show the relationship between the psychiatric symptoms and the disorders. When they get a new treatment, evaluate the psychiatric symptoms before and after. And you'll be able to add that to the story, because right now, the psychiatric part of the story is not being told, because we're not at the table. Then we've got, the ones that are not yet diagnosed, and you can do the most important thing you do is your clinical workup and ask the right questions, and you can help reduce that unknown group. And then we've got the new diagnoses that are coming out, and we're trying to build tools, and that's where the research and development comes in. Where do we even start? Here we are as psychiatrists, and every single puzzle piece is a different patient, and we're sorting them into groups. And so we have our depression here and our anxiety there, and we have psychosis over here, and we're throwing pieces at each other because sometimes we can't decide which pile it should be in. How do we find the autoimmunity in this? You'd be surprised how many don't go backwards and read everything in the medical journal. And you can't do this for every single patient. It takes too long. But when you get a patient that, like, this is weird, open the entire medical history. Make a timeline. Put all the symptoms and everything else they've had that's happened to them on the timeline. That sometimes helps crystallize these like trajectories where there's this fall in function that comes quite suddenly. Ask backwards. How was it in the month before? Did you have an infection? Yeah, I had a really bad influenza, and the symptoms started 2 weeks later. Then you've got your first red flag. Look at the family history. That gives a lot of clues. Try and pick out the immunological themes. What type of immunological comorbidity do they have? Because that gives a lot of hints on where maybe the focus should be. All of the bodily symptoms, work systematically through them and negate them when they're not there, and notice the changes when they do show up. Do a proper medical examination. So look at fingernails for pitting. Look for any type of skin disorders. Ask about membranes. Ask about GI symptoms. And if they do have a comorbidity, optimize the treatment for that comorbidity together with the other specializations involved. And the patients, I meet so many patients that have been so gaslit. They're talking about, weird side effects to the medications. And it's in this group I'm seeing really weird side effects. Listen to the patient. They're not always interpreting it right, but their experience is always correct. And immunotherapy does reduce psychiatric symptoms when given in a patient with an autoimmune disorder, and that's been shown in a meta-analysis level. So in our multidisciplinary team, we evaluated in the first cohort, and we've just repeated this, but it's the same type of numbers, 127 cases. We had 43 cases where there was an autoimmune disorder, and like in 6% of the cases, that was our evaluation that gave the new diagnosis. And then we went on to say, okay, can we optimize the treatment or introduce treatment to help the patients, which we did in 29 of the 44 cases, and a clinical response was seen in 22 of these cases. And so you can really make a difference when you do it this way. And now got you guys all enthusiastic, and you're going to go out and you're going to take a lot of tests, and don't do that. If you don't have this as a routine in your setting, you have to choose your first cases really, really carefully, because you can burn the bridges very quickly. So if you're just starting out here, really wait until you get the most obvious case you can and start there. And so, look for the SLE cases, look for the ones that have a Sjogren's syndrome, look for the ones with a known autoimmune disorder, and start there. And you'll learn something from every single case you work with. And then we have the red flags, and they're being further developed. There's another consensus document that we're hoping will come out in Lancet Psychiatry in the near future here. But the red flags we have right now are prodromal infection, neurological symptoms, cognitive impairment, catatonia symptoms, not responding to treatment. If you have a hyponatremia, you have to think of one of the autoimmune encephalopathies with the LGL1 receptor antibodies. Impact on memory. Your NMDA receptor patients often don't remember their episodes. Then the yellow flags are, other autoimmune disorders, the age of onset, headaches, somatic symptoms, among other things. If you're doing CSF, cell count, bands, so if there's any type of antibody production in the blood-brain, inside the blood-brain barrier, that's of interest. The damage markers, I really like NFL. It's hitting a lot of my SLE cases, for example. And then there's specific antibodies. And when we do this, we find abnormality in about 27% of this enriched cohort. So selecting for the red flags and then looking at that cohort. 1 in 4 have a finding that we think is interesting. So in this group here, that have markers for autoimmune disorders, but we don't know, in the group that have markers, but we don't know what diagnosis it is, we've gone forward and done a clinical trial with rituximab. So that's a biological antibody that is given to patients with MS. And this is just preliminary data. We're about halfway through the trial. BPRS is the endpoint. And at the start and after 16 months, we know everyone has gotten treatment at some time, but we don't know when. We're getting a really nice reduction in symptoms. And actually, I have patients that have gone from full-time service home care with around-the-clock service to their own apartments and university studies. Like, it's mind-blowing. When you get it right, it's fabulous. But I'm not helping everybody. I've got patients that haven't responded at all, and so one of the jobs we have in front of us is the biology to try and figure out what was the difference between the one that really responded and the one that didn't. And I do want to stress the fact that this is not psychosis. I've really enriched for patients I think have a T-cell activation and a B-cell activation that motivate this type of treatment. So our big problem is the DSM. The symptoms are not attributable to a medical condition. The minute they are, we boot them out of psychiatry. So it's not that psychiatry is not discovering things, we are, but the minute we do, we send them to another specialization and then we leave the table. And that, I think, holds us back, because then we're not following the stories and we're not learning and we're not extrapolating that information backwards to other patients. So my plea is, I would love us to start getting closer to the other specializations and following these patients. And I think we're going to see that there's a gray zone that we can use the same way of thinking on, and I think we can diversify ourselves in a very efficient way that will really translate to patient care. The WPA is in Stockholm in September, and Stockholm in September is beautiful. So we're having a CME course, so it's a half day, and it's going to be really close to the clinic, rheumatology, microbiology, the radiology. We're going to talk about the different types of immune system problems we're seeing in our patient groups, a lot of practical tools. So join us. We have also 2 symposiums about immunopsychiatry with a child and adult focus. So I'm really excited about this. So welcome to Sweden. And this is my group. It's actually a short list. I've got a lot more collaborators, but I have no more time, so I have to say thank you.